Good afternoon. Welcome to this year's Coggeshall Memorial Lecture. Behind me you see a picture of Lowell Coggeshall, who was born in 1901 in Saratoga, Indiana, and graduated from the Indiana University Medical School. First came to the University of Chicago in 1928 as an intern, stayed on the faculty until 1935. He was a specialist in infectious disease and malaria. During World War II, Dr. Coggeshall served as chief advisor to the U.S. government's malaria project. He was asked to develop a safe, effective, once-weekly malaria prophylaxis, which he did by combining high doses of chloroquine and primaquine. After the war, in 1946, Dr. Coggeshall was recruited back to the university by President Robert Hutchins and served as the Dean of the Biological Sciences from 1947 to 1960. While Dean, Dr. Coggeshall moved easily between Chicago and Washington, D.C., and was a special advisor on health matters to Presidents Eisenhower and Nixon. In fact, in 1956, Cog moved to D.C. for a year to serve as a special assistant to President Eisenhower on health issues. In 1965, he authored for the Association of American Medical Colleges the famous Coggeshall report called Planning for Medical Progress Through Education. Among Cog's greatest achievements was that he changed the AAMC from a small regional dean's club that was headquartered in Evanston, Illinois, and moved it to Washington, D.C. To make it the powerful and effective voice it's become for academic medicine. I first met Dean Coggeshall and his late wife, Becky, in Foley, Alabama in 1967. Actually, it was during my honeymoon. I wrote Cog to ask if I could drop by to talk about some of the early history of the medical school and about Franklin McLean, and Cog graciously extended an invitation. My wife, Anna, sometimes chides me that even on our honeymoon, I was working. The Lowell T. Coggeshall Memorial Lecture, is an annual event that the McLean Center and the Pritzker School of Medicine have co-sponsored beginning in 1989. Holly Humphrey, who's in the audience, and I work each year to select our speaker for the following year. I show you up here a list of previous speakers in this series, and some of you may not be able to read it from the back, but it is a kind of who's who of American medical education. And many of the previous speakers, those with an asterisk after their names, had affiliations with the University of Chicago. And this brings me to our distinguished speaker today, Dr. Adam Cifu. Adam is a professor of medicine here at the university, where he joined the faculty in 1997. He earned his BA from Haverford College and his MD from Cornell University. He did his residency in internal medicine and a year as the primary care chief resident at the Beth Israel in Boston. Adam Cifu is a general internist who divides his time between clinical practice, medical student education, and scholarly work related to evidence-based medicine. He co-directs the third-year medicine clerkship and directs a very popular fourth-year medical student course called Critical Appraisal of the Landmark Medical Literature. Adam is the co-author of a textbook on clinical reasoning for medical students called Symptoms to Diagnosis, an Evidence-Based Guide, and more recently co-authored a book called Ending Medical Reversal, Improving Outcomes and Saving Lives, a book for both professional and lay audiences that discusses medical reversal and evidence-based medicine. Adam serves as a deputy editor of JAMA's Clinical Guidelines Synopsis series. Adam has won many honors in the past, but the one that really strikes me as extraordinary is that for 14 of the past 15 years, he's been selected as a favorite faculty member by the graduating class of the Pritzker School of Medicine, and is a master in the Academy of Distinguished Medical Educators at the University of Chicago. Today, as the slide behind me shows, Adam will speak to us on the topic of medical reversal. Please join me in welcoming Adam Cifu.
Thank you. Boy, thank you, Mark. Sat here for so long listening to introductions like that, and I've never really realized how much pressure it puts on you. Even worse than seeing that list of the previous speakers. So thank you very much for inviting me, and thank you to the Coggeshall family, who had a wonderful dinner last night. It was great meeting you guys and getting to know you. So I'm going to talk today about medical reversal, which is a topic dear to my heart, and hopefully I'll convince you that it should be yours by the end. So what is medical reversal to begin with? So medical reversal is when a currently accepted practice, a practice that has been accepted by doctors and deployed and used widely, is overturned. Generally, it's found to be no better than a therapy it replaced, or sometimes actually it's found to be no better than any therapy at all. It generally occurs, or maybe I could say it always occurs, because that therapy which has been accepted was not accepted based on any robust data to begin with. This is sort of just a schematic of what it looks like. And I want to differentiate reversal from replacement. So replacement is how we sort of expect medicine to evolve, right? We have a really good therapy, something we're satisfied with, and then a new therapy comes along and we find out that that new therapy is better. And that's what we want. That's how medicine should evolve. Reversal is a little bit different. Reversal, we have an accepted practice, data comes along, we accept a new practice, we get it out there, and then robust data comes along and shows us that this new practice that we've sort of all bought into actually is not the best thing, and maybe we shouldn't have changed in the first place. There are a whole bunch of things that's not reversal, and as soon as you start talking about things like this, everybody like labels you as a nihilist, and they figure you're against everything. And I'm certainly not that at all. Probably the biggest thing that everybody says is that, oh boy, any negative study you read is reversal. That's absolutely not true. Most negative studies that we read are studies of brand new practices that are being robustly tested that turn out not to work. And it's kind of, okay, back to the drawing board. And that's just science, right? We're good with that. And so reversal is different. So before starting, in an attempt to get you guys onto my side, I want you just to sit for 10 seconds and reflect on things that you've done over your careers. Medications you've prescribed, procedures that you've done, procedures you've referred people to, surgeries that you've referred people to, that later on you find out, that was actually the wrong thing. I've been doing the wrong thing over the years. And I think that even people who are pretty new at this can come up with those, I hope. And if you can't, you're probably not reflecting hard enough. So this is sort of my list, the list that I keep dear to my heart of a whole bunch of things. And they're not all absolute reversals, but they're things that I think about that I often question whether I was doing the right thing in the past. So my outline, I've already talked about definitions. I'm going to throw out a couple of examples, and these are certainly not the newest examples. They're just examples which really hit home to me, and I think do a good job of explaining reversal. I'm going to talk then briefly about the frequency of reversal. So how common is reversal? Is this like a public health disaster, or is this just something interesting? I'm going to spend also a little time, maybe just one slide, talking about why we should care about this, sort of what the harms of reversal are. Probably spend the bulk of this talk talking about the causes of reversal, which I find is sort of the most interesting thing. Why does this happen? And that's a little bit to a root of that, well, if you buy that this is common and you buy that it's a problem, then that says, okay, what can we do to make this better, or make this less common? So let me start with vertebroplasty. So compression fractures, we all know, are a big deal, right? Patients come in, they feel terrible, they're in horrible pain. And for years and years, we've had little to offer except pain control, maybe some calcitonin, something to make them feel a little bit better. 700,000 vertebral compression fractures yearly, which is pretty impressive. About 300,000 of them are clinically important, meaning it brings patients to the doctor. Vertebroplasty, for those of you who don't remember, is injection of medical cement into the vertebral body. And it's really an ingenious idea. And everything that I'll talk about sort of sounds great, and it's one of the reasons it's adopted. The idea is that you have a collapsed vertebrae, you inject medical cement in there, you kind of reconstitute the structure of the vertebrae. People should feel better. It gives the nerves a little bit more room to breathe, feels better. Developed in the late 1980s by radiologists, and was FDA approved in 2001 based on 11 trials. Not great studies or study types, as you can see here, but enough to get it approved. And by 2009, this became big business like everything. So over $1 billion was being spent on vertebroplasty per year. And then in 2009 came really the first really, truly robust studies of vertebroplasty published in the same issue of the New England Journal of Medicine. They're pretty much identical. I'm just going to focus on one of them. It was a great study, 131 patients, so not a big trial. And patients were randomized either to vertebroplasty or sham vertebroplasty. And sham vertebroplasty, like if you're a fan of sham procedures, this was the best. So they took people to the operating room or to the procedure room. They prepped them, they draped them, they gave them a little bit of benzo to relax them. They even actually opened the medical cement so the patients could smell the cement and be convinced they were getting the injection. But then instead of getting vertebroplasty, they just had saline injected into the vertebrae. And not surprising, since I'm talking about it, both groups had identical improvements. And usually when we sit in grand rounds, right, we see slides with all these huge differences. Pretty much all my slides are going to look like this, where like nothing happens. So this was impressive. So this was over the first month of follow-up, and this continued. So my next thing, which is probably have been more exposed to, or maybe exposed more patients to than vertebroplasty, was renal artery stenosis. So certainly in medical school, we all learn, oh, renal artery stenosis, one of the secondary causes of hypertension, of course, really closely associated with both hypertension and chronic kidney disease. The quoted mortality is enormous, so 16% per year in some studies. That's obviously hugely biased because it's not just people with renal artery stenosis, it's people with renal artery stenosis who are sick enough to have their renal artery stenosis diagnosed for some reason, but whatever. By the late 1990s, revascularization, either surgical or really more importantly, catheter-based, was becoming very popular, really because it just made so much sense mechanistically. And it was growing sort of in the late 1990s, up 62%, at least as far as Medicare payment. And then came just a whole slew of studies which really have to make you question stenting or opening renal arteries. The first 3 studies just looked at blood pressure control. The next study in 2009, the Astral study, showed effect on renal function. And then their latest one, the Coral study, in 2014, looked at the effect on cardiovascular endpoints. And I'll show you a couple of these studies. So the first one is Astral, and most of these you guys are probably all aware of. I'm less trying to put forward new data, but more, I guess, trying to get you to think of old data in new ways. So this was 800 patients randomized to either optimal medical therapy or renal artery stenting or angioplasty plus optimal medical therapy. Main outcome was change in renal function, but tons of secondary outcomes they looked at. And as I said, no benefit to this in renal function over 5 years. I'll show you some of the outcomes. No difference in blood pressure. And this came with some harm. So of the patients who had revascularization, there were 23 complications, including 2 deaths and 3 amputations of toes or limbs. So not ideal outcomes. This is the change in renal function. Again, some of my beautiful no difference slides. Here's blood pressure control. Here's first renal event and first cardiovascular event. So pretty definitively negative. The next trial, the most recent from 2014, was the Astral trial. And this tried to take a step back and say, well, if it doesn't help blood pressure and it doesn't help the kidneys, let's look and just see if it helps anything. And so they used a composite endpoint of major cardiovascular events. And of course, see a very, very similar outcome with no difference in the event rate over the course of the trial. Last one is kind of ancient history, but I'm especially attached to it. for reasons that I'll talk about. So atenolol, popular antihypertensive drug, really in 90s, 2000s. It, for a while, was truly a trial standard, right? If you wanted your new antihypertensive approved, you had to show that it was at least as good as atenolol. I like it because we had this ridiculous assignment at the end of medical school that if you're going to do internal medicine, you had to do this project where you basically wrote a tome about 20 drugs that you were particularly attached to for some reason. And atenolol was my lead drug. So I was like, oh, it's medicine, it's hypertension, everybody uses atenolol, let's do this. The fall of atenolol started all the way back in 2002 with the LIFE trial, which was just your standard antihypertensive trial. It was comparing an atenolol-based regimen with a losartan-based regimen. Big trial, long trial, primary endpoint, death, MI, or stroke. So your sort of basic hypertension trial. And it turned out that losartan was just as good as atenolol at controlling blood pressure. Great. But when we looked at the composite endpoint, it turned out that losartan was better than atenolol. So this is really replacement, right? This is, we have a drug that we like, we have atenolol, a new drug, in this case an ARB, losartan comes along, and it shows that, well, it's just as good as controlling blood pressure, but it's better at controlling endpoints, which is a little bit surprising, but whatever, we're okay with that. These are the data from the study, and so it was really, significantly better. Number needed to treat of just 53 to prevent that composite endpoint. Where reversal came in was a couple of years later when this meta-analysis was published in The Lancet, which looked at atenolol not against another drug, but it looked at atenolol against placebos in multiple trials, where atenolol had been shown to be beneficial as far as lowering blood pressure. And it did, in fact, lower blood pressure, but it really didn't have any change in the clinical endpoints. That's the reason we treat hypertension, right? So here, got all-cause mortality at the top, cardiovascular mortality, MI, barely a benefit as far as stroke. And so this took atenolol off most people's lists of commonly used antihypertensives. Okay. I threw in this because I just couldn't let this go, but it was sort of too late to make it a whole thing. This is news from Friday that came up on my little Medscape alert about the FDA taking the unusual step of withdrawing approvals it had previously given for niacin fenofibrate in combination with statins for control of cholesterol. So sort of a great example, right at the last minute. And I'll get back to this a little later when we talk about causes and talk about the importance of surrogate outcomes for that. So how common is reversal? So as I mentioned, is reversal just really notable when it happens? And it's something that, oh my God, I thought renal artery stenting was so good, and now I'm not so sure. So you remember that, especially when you see that patient every 3 months, who had the stent placed. You're like, what did I do to this person? Or is it really common, and it's something that happens all the time? So the answer to this question is we have no idea. It's sort of an unstudyable thing, right? If you think what you'd have to do, you'd have to take basically everything that we do in medicine, right? And then look up the trials which supported that. Sometimes you'd find that, yeah, this works. Other times you'd find that, no, it doesn't. Why are we doing this? This is a reversal. We should stop doing this. But then a bunch of things you'd find out, there's pretty soft data behind this. We've got to design trials. We have to test these. It'll never happen, right? It's hard to get a good number. But a bunch of groups have tried to come up with these numbers, and I'm going to take you through a few. So the first example was by John Ioannidis, who was here just a month ago, who's admittedly like one of my heroes, and I'll pull up a couple of his studies as we go. And his idea was, well, let's not look at everything we do in medicine, but let's look at the things which we really think are important. So he pulled the most highly cited research over 13 years and came up with 45 trials. He used a cutoff of 1,000 citations, right? So like the total home run trials, the things that we all dream of writing, I guess. And then over the years after that study, he tracked follow-up studies of those interventions' efficacy. And what he found was that 16% of these were found to be later just completely ineffective, 16% less effective than thought. 44 were actually supported in future trials, so like this was good, this was in advance. And then about a quarter were just never studied again. So we're left with, I don't know, maybe they work, maybe they don't work. In 2011, the British Medical Journal basically funded a trial. I'm not even sure I'd call it a trial, research to try to figure out this question, how common or how likely are things that we're doing that they could be reversed. And this is about what they found. Let me get my pointer. So they found that 11%, and these were 3,000 common practices. This is obviously very important for a national health system, were definitively beneficial, 24% likely to be beneficial. This group here of about 15% that were either a toss-up or maybe definitively unlikely to help. And then an amazing, really 50% were things that just didn't have adequate data behind them. So this is the group that if you studied this, you may turn up lots and lots of reversals. Similar study actually in Australia, which took less of the, we're going to start with medical interventions, and more we're going to start with the literature and see what we can come up. They did a ton of work, looked at over 5,200 studies, and came up with 156 commonly used practices, which they decided these are unlikely to be effective. This is just the data from that. This is the effort that my colleagues and I worked on a couple of years ago. We decided to go in a similar way as the Australian group, but focus on just one journal where we figured, okay, we're going to look at the best data we can find. So we chose the New England Journal, and we said we're going to look at 10 years worth of articles, okay? Basically, every original article that was published in the New England Journal over that time, and figure out how many of those are reversals. And we came up with actually really cool data. Obviously, this doesn't say a lot about how common reversal is out there, because all these numbers are so affected by what the New England Journal chooses to publish and what their editors think is important. But it's interesting as far as what it turns up and how much we see. So there were 363 articles which tested an established practice, okay, which was a lot, actually, when you think about it. These were sort of very brave researchers who said, we've been doing, meniscectomies for knee OA. Let's actually see if that works. And we found out that there were 146 of these that were reversals. Things that we were doing did not work. And that was about 40%. 38% basically affirmed the new practice. Yeah, this was based on not so great data, but when we actually study it, it works. And then 22% were inconclusive. I'll throw out, this is what the list looked like. And it was, I think of this when I sort of read the New England Journal and think about what they publish. So 2,044 articles, about 2/3 were about medical practice. The other third were basic science articles. About 3/4 looked at a new practice. Most of those found that the new practice was better, so it's kind of replacement. And this is the 30% that we were really interested in over here. This stayed constant over the years, and ever since we finished this, it's sort of my fun thing to do in January is to look this over, and it turns out to always be about the same. The New England Journal seems to like to keep about 40% of their articles reversal. So harms of reversal. So why do we care about this, right? Or I guess maybe why do I care about this? You can tell me afterwards if you care about it too. So the most important thing, certainly, as practicing doctors, is that when an intervention is reversed, it means that patients who got this intervention before it kind of fell out of favor, those people were harmed, right? So at very least, they received ineffective care, and there was an opportunity cost, right? They could have gotten something that worked better, or maybe they could have been enrolled in a trial that was studying something else, right? There's something better that could have gone on. There's always a monetary cost, right? Nothing we do these days is cheap. People have to pay for their vertebroplasty. And then sometimes, though admittedly rarely, there's physical harm associated with that intervention, which falls out of favor. So there are some people in the vertebroplasty literature where the cement that was injected into the vertebral body, migrated to other places and caused problems. Second harm is that de-adoption is never rapid. When something falls out of favor, when something that we've accepted and we've decided, this is good, falls out of favor, and we find out that it doesn't work, it doesn't just disappear. Everybody just doesn't stop using it the next day. People didn't stop using atenolol the day after that meta-analysis came out. And if you look at the literature, it turns out that things probably persist for about 10 years. If you look at citations of the original articles supporting the reverse therapy persist in the literature for about 10 years after it's reversed. I'll show you a little bit about why that happens in a second. And then third is loss of trust in the medical system, right? I always say I still have a number of patients who I put on estrogen replacement therapy in the mid-90s. I took off estrogen replacement therapy in the late 90s. And now seeing them when they're in their 70s and 80s, they still bring that up to me every time I write them a prescription. And they're like, well, remember that? I'm not doing it. This was kind of a cool trial, just to talk about that whole de-adoption issue and why de-adoption takes a long time. Yeah, there are probably all sorts of reasons why de-adoption takes a long time, but this is one of my favorite. These were people who said, let's just look at 20 examples of reversal. They choose some medical, some procedural, some screening tests, and they looked at the editorials that were written in journals. And they compared editorials that were written just by recruited people to write editorials, often EBM people, with either editorials or other articles that were written by people within the subspecialty that was affected by that. And you won't be surprised by the results. So this looks at whether the journal editorial or specialist society-sponsored writings either supported continuing use of the reversed practice or challenge continuing use. And not surprisingly, if there's an editorial written by someone whose specialty is affected by this, they're more likely to say, maybe we should keep doing that and get more data rather than accepting it and saying, boy, this is right, we should give up on this. And it's not all money, right? It's not all that you're making money on this procedure. It's that people have done this procedure. They've seen people get better. They believe in the procedure. And it's hard to give that new thing up. Okay, so causes of reversal. So I'm going to spend some time just going through this and talk about why this happens. And this is just sort of what we realized as we sort of looked through all these things and said, let's look at the articles that people relied on to say this new practice works. And were there any common themes behind those? The greatest common theme is, I think, our faith in mechanistic arguments, right? When we start medical school, our first 2 years is all about how things work. And we really buy that, right? And so if you hear a really good argument about why a procedure or why a drug should work, the pathophysiology looks perfect, the anatomy looks perfect, you're like, yes, that's going to be terrific. And you may be apt to sort of take, well, not quite robust evidence as support for using it. Then what happens after that is there's a lot of inadequate data out here that people rely on. Here's a bit of a list, and I'm going to talk about this. The most troubling part is that there's also a lot of really good data out there. So even sometimes when we read the best trials we can, really robust randomized controlled trials, those also sometimes steer us in the wrong direction. And we'll talk about some of those. So the first thing is observational trials, right? Which we sort of all know this, right? We're all schooled from the beginning that observational trials show association, not causation. There's that fabulous XKCD cartoon about this that I was going to show, but I'll hold on. And that's even with sort of the best new statistics. This is really still true. Obviously, we can get close to showing causation, but never quite get there. Observational studies are not worthless. They are, in fact, incredibly useful for delineating prognosis. They're incredibly good for hypothesis generation. We need observational trials. But basing medical behavior on that, practice behavior, is probably somewhat sketchy. Because sometimes, not always, but sometimes they come to different conclusions of RCTs. And I'll show you some data on this. So this is a trial back in 2001, which was really a nice effort. It took topics that had been studied with both RCTs and observational trials and compared the results that they came to. So 45 topics, they had 240 trials, 146 non-randomized trials, and they compared those. The correlation was excellent, right? Like really good. But there was a lot of play there. So more heterogeneity among the non-randomized trials. Non-randomized trials were more likely to show a larger benefit. And sometimes, depending on sort of how you drew the lines, they reached different conclusions. And so the sometimes is the hard part, right? If they always reach different conclusions, we'd be okay. But the sometimes, you're not sure when your observational trial is leading in the right direction or the wrong direction. This data, I thought a lot about this because I'll show you the correlation curve, which looks great, right? I mean, yeah, sure, there's some that lay off, there's some which are in the wrong place completely, but for the most part, it's good. And I've thought a lot about this. Boy, our observational trials sort of better than I thought. But if you think about what gets examined in both ways, this probably overestimates even how good observational trials are. So you think about how many observational trials you read, which are just things that can't be evaluated in randomized controlled trials. So we're missing a lot of data. I think of that a lot with the PPI and dementia article from, I guess, last December, which to my read, was kind of a terrible observational trial. The groups were completely different. They only controlled for about 6 different issues between the users and the non-users. The biologic plausibility between a PPI and dementia is hand-waving at best. And yet this had a huge effect. I mean, I think I've spent at least a dozen visits talking to patients about their heartburn and their pending dementia since then. So, okay, this is just to say we are not without blame in this. If you take us as sort of the authors who put this stuff forward, this is a trial that we did back a couple of years ago. That we looked at articles in 4 journals, and we specifically picked good journals. We wanted sort of good, robust articles. And we just wanted to see what authors did with their observational trials. And what they did was this. So these were the non-randomized trials. Over half of the authors of non-randomized trials made a practice recommendation based on their data, and pretty much all of them didn't call for randomized data before that. So we are to blame at saying, this is a cool result. We should start doing things differently because of this. Next topic is sort of a cause of medical reversal is subjective endpoints. So subjective endpoints without adequate controls really set you up for reversal. And we're sort of good at this with drugs, right? I mean, you read randomized controlled trials, and boy, they do a terrific job of coming up with blinded placebos. We're not as good at this with surgeries and devices just because it's harder to do those, right? It's harder to do sham surgeries. It's harder to do sham devices. But here's a list, and I go all the way back to this famous internal mammary ligation back in 1959 of things which have been accepted based on pretty good studies that showed a benefit of the procedure. But then when it was controlled for with a really good sham control, we find out that it didn't work. Orthopedics has come under a lot of fire lately with these. We have at least one orthopedist in the audience, which makes me nervous to say. This is a slide, a study. Actually, Dr. Lembo, when he was here a couple of months ago, actually showed this study, which is a wonderful example of the placebo effect. This is with asthma. These were patients who were treated either with an albuterol inhaler, placebo, not acupuncture, but sham acupuncture, or no intervention control. And this is the effect on FEV1. And obviously, albuterol works, right? It's good. If you ask people, though, just their subjective feeling of asthma, it turns out that albuterol is no better than placebo or sham acupuncture. So even with the placebo, we convince people that their breathing is better than it actually is. This is a study that actually came up in the my 4th-year course that Mark mentioned that one of the students presented. And I lost track of the entire article because I got so obsessed with this one table. So this is responsive cortical stimulation, which is basically ICD placement for seizures. So they take people who have focal seizures, which then generalize. They plant a stimulator into the place that the seizures develop. When a focal seizure is beginning, then they stimulate that area to kind of override the seizure from generalizing. It's like amazing technology. And so what they did in this is they took a bunch of people with really, really, really refractory epilepsy. They put in the device in all the patients, but they only turned it on in half the patients for the first 3 months. And so you can see first, it's pretty good, right? I mean, these are people with horrible seizure disorder, and they get like a 30 to 40% reduction in seizures. But check out the placebo period. You get a pretty remarkable drop in seizures with this. And it follows what we'd expect as sort of a decline with the placebo effect, that it's strongest at the beginning and then it falls off. So the placebo effect is real, and it's real in some things that we might not think it would have an effect in. So surrogate endpoints. We all rely on surrogate endpoints, right? Running studies with clinical endpoints is incredibly difficult. They have to be long, they're expensive, we have to use them. But the problem is that surrogate endpoints sometimes lead us astray, because even surrogate endpoints that seem really, really closely associated with the endpoint sometimes don't work. So there's another one that I put up a ton of these going all the way back to the CAST trial, which probably every medical school statistics course starts with. Yeah, boy, it makes sense to suppress PVCs in people post-MI, but it actually leads to more arrhythmias and more death. And then a bunch of newer ones. The cholesterol ester transfer protein inhibitors is probably actually the greatest example recently. These are drugs which have unbelievable effects on lipid. But so far, all 3 drugs have failed to improve clinical outcomes, and the pharmaceutical companies have basically given up on those 3 drugs thus far. I put up hospitalization here just to sort of hurt everybody's minds a little bit. Hospitalization is one of those things that, hospitalization, that's not a surrogate endpoint. That's like a real endpoint. I want to decrease hospitalizations. This is sort of a neat look where they took studies that looked at both hospitalization and mortality as an endpoint, okay? So they looked at hospitalization both as a clinical endpoint and as a surrogate endpoint. And it turned out it wasn't such a good surrogate endpoint because 8% of the time, the endpoints went in different directions. So an intervention which decreased hospitalizations actually increased mortality, and an intervention which decreased mortality actually increased hospitalizations. So interesting information, probably both very valuable outcomes. And then lastly, I'm going to talk about well-done randomized controlled trials, right? So okay, all these other ones we're suspicious of, but what about RCTs? RCTs are sort of our gold standard. We have to go through this. We have to go by these. So can these lead us astray? So the first is error rates. And error rates is something that we all know well, but maybe have not thought about it in this way. So think about a trial that compares a new treatment to an established one, okay? And the new treatment is found to be superior. So generally say, great, replacement, we're advancing, we're happy about that. But how likely is that to be true, or how likely is that to be a false positive result? So we have to have 1 2x2 table in this talk, right? And so here it is. And I sort of moved around the columns and rows to make it make a little bit more sense clinically, right? So this is truth. This is that your new therapy is we'll just say better, okay, is different, is better than the old therapy. This is no difference. And this is what your study results look like. And so here's our alpha error, here's our beta error, okay? And if you think about what the relationship in sort of the global literature of randomized controlled trials are, this ratio should probably be at most 1-to-1, given equipoise, that we really shouldn't be doing randomized trials that one is clearly, clearly better than the other. So you might take that as just a given or an assumption. And if you say, okay, well, let's throw out, 1,000 trials, okay, over the course of time and see how these things break down. And if you just look at positive studies, these are the numbers you get. So you get about 400 true positives and about 25 false positives. So that's pretty good, right? So that's 94% positive rate. I'll be happy with that. The problem is if you think about things like, I'm trying to think of an example. For me, it was all those trials last year of remote ischemic conditioning, where you read the abstract and you're like, this can't possibly work, right? Or things that you hear maybe on NPR in the morning where they're like, shocking breakthrough. And you're like, I can't imagine that works. Well, so how about if there's only a 10% chance that it works, a 10% pretest probability? Well, then if a positive study is true, that means it's only about 64% that it's a true positive, okay? That's not very good. And that's assuming that everything else about the trial is perfect and there's no publication bias out there and nothing else, which we accept very few are. Okay, early termination of RCTs. This is actually an obvious one, but one that I often don't think about. So trials are terminated early. They have to be terminated early if we find that something is really markedly better, right? It's unethical to continue the trial when one thing is better. The patients were signed up for that trial saying that we don't know which is better. So once we find out, we have to stop the trial. But it turns out that trials that are terminated early pretty much systematically overestimate the benefit of that therapy. Here's a nice study from 2010, which looked at 63 clinical questions for which we had multiple studies. 91 of those were terminated early, while 424 were allowed to run to their conclusion because they weren't showing such a large benefit. And here's the numbers. So on average for a clinical question, if a trial was run to its conclusion and found no effect, a study of the same intervention, and these were like matched trials, that was stopped early concluded that the treatment was associated with a 29% benefit, okay? So you're putting these together, you hear something which shouldn't work and the trial was stopped early, you should not say, that's a home run. You should say, boy, I would love to see, the next round of trials about that. Single center studies, I think we're all aware of this, we're all suspicious of these. Single center studies can be idiosyncratic, right? The patients are different from place to place. I think this is especially true for systems interventions, right? Where one really kind of charismatic, convincing person at an institution can really kind of move the needle on how people behave. But you transfer that to another hospital where that charismatic figure does not exist, it might be hard for people to change behavior and change the way the system works. Here are a few examples. I'm not against putting on gloves and being clean, but we've had a really hard time showing that that benefits when you take it out of single center studies. And then very last is publication bias, okay? So we all buy publication bias, right? Even small positive studies are more likely to be published than small negative studies. And you look at all the meta-analyses you read, and they always have those beautiful funnel plots, and it's rare that you see a funnel plot that says there is no publication bias in this field. And there have been a couple of attempts to sort of figure out, so how common is publication bias? This is one of my favorite that I actually stole from Dr. Chirpek during the first year course, which was from 3 different psychology journals back in about 2010, I think was the year, 2010, 2011. And it looked at just the p-values in all the trials. And this was the line that they used in the conclusion, which I just love, a peculiar prevalence of p-values just below 0.05, like they didn't know what was going on. And you see this very interesting decline in p-values as you go forward, and this interesting little jump in p-values, just less than p equals 0.05. Here is it shown in another way. And then Peter Ubel, this is unpublished data, but did the same thing again last year with an enormous number of trials from Google Scholar, okay? And plotted all the p-values right around 0.5. He suppressed this because this was like somewhere up there, it was off the charts. But that's amazing, and it's hard to explain that in any other way that there's publication bias. Not necessarily on the journal's behalf saying, negative, we're not interested. But maybe on the researcher's behalf, maybe on the people who are paying for the research, who knows? So in summary, reversal occurs when an accepted practice is overturned, okay? Causes, underlying it all is our faith in the mechanistic system, mechanistic explanations. Inadequate data then sort of piles on top of that, okay, that we're probably not suspicious enough, or maybe our threshold isn't high enough for the data which convinces us to use things. And then there are misleading RCTs. So, we do our best, but there are either errors built into the RCTs, or there are errors in the way that the RCTs are designed or run. And sometimes those errors are true errors. Sometimes those errors are intentional errors. And so just recognize, some percentage of what we do doesn't work. And when we use ineffective therapies, people are harmed. So the hardest part of this is, what can we do about this? And when I'm feeling like I need some punishment, I read the reviews of our book on Amazon, and pretty much all of them say, the book kind of falls off when you get to the solutions section. I was like, yeah, whatever. Because this is hard, right? I'm not sure how you figure this out. The first one is such a throwaway line, but it's probably true that thinking about our ethics and saying, boy, we should sort of commit to practicing from a firmer evidence base, and that maybe not the newest thing, which is kind of a Me Too drug supported by surrogate marker studies. Maybe that's not something to jump right onto. Maybe we should wait for better clinical endpoints. I've certainly been burnt by surrogate markers more times than I care to discuss. Lessening bias in study design, And who knows, maybe better oversight for sponsored research. There's a whole literature out there about how trials are designed to overestimate the benefit of drugs, whether it's how the standard care is given, what the standard care is chosen, what the dose of the standard care is, or issues with blinding. And then, maybe the change in the way we train doctors. We are really all inculcated in this whole, mechanistic view of medicine. And it's wonderful. We have to learn the sciences. We have to know this to be doctors and push medicine forward. But I think that really does get in the way a lot with making clear-headed decisions, because we're just so convinced that, wow, look, I saw this slide about this receptor and this drug binding to the receptor. This has to be good. But the fact is that, we as humans are complicated, and when you move that from the lab to the person, sometimes it doesn't work, or sometimes it does work, but it has all sorts of other effects that negate the benefit of the intervention. That's all. So I want to leave some time for questions. Thanks. Okay. Any questions I can answer? Or any people who say, I want to keep doing this and stop? Yeah.
So, that was a really great talk. One comment would be, what do you think about, you mentioned talking about, using our prior knowledge and focus on p-values. So, what do you think about something like Bayesian statistics, right? Something that I think the Bayesians think that, well, if we just use prior probability, our prior knowledge, and focus less on the p-value, focus more on just trying to get the effect size just right.
Right.
Then maybe that would improve the, some of the issues with p-values and p-value hacking and the other things.
Yeah. Yeah, so, I absolutely agree with that, right? And I think as clinicians, right, we're all Bayesians, right? Every day we see a patient, we're immediately thinking about pretest probability, and we're immediately thinking about, okay, am I going to get this test because it'll revise our pretest probability? Well, why don't we use that more in the literature? And I think we should, but I think the obvious problem with that is the same problem that we have as clinicians, that sometimes that pretest probability is so kind of squirrely. Sometimes there's data for it. Other times it's clinical experience, which is affected by what we've seen recently or what we've missed recently. And I think a lot of the times in the trials, you're not entirely clear, where we're starting. But I love the idea of just saying, boy, this is the trial. This is how great this benefit is and how much it would affect pretest probability, and letting people make their own decisions based on that. It's a big step, though, right? Yeah.
I'd be interested in your take on the free open access education or COMED movement, and how that impacts kind of our adoption of new practice and its impact on them.
Do you think for students or for practicing doctors? What are you?
I think it's really probably students and residents who are the biggest adopters of COMED
Yeah.
into their practice. So
Yeah.
middle management,
Right. I'm not sure. I'm just not, I think our journals, for the most part, do a terrific job about vetting the research that gets into them. Obviously, there are very splashy examples of where they haven't done well. But as someone who's had my share of things rejected, I like to think that they have very high standards, right? And so this might sound so conservative, but I'm a little bit worried about, opening the doors to everything and having people be on their own reading and assessing those trials, which hurts me to say as someone who's kind of committed to teaching people to read that, but I kind of think it's true. I don't know. Do you think differently? Or?
No, I'm trying to incorporate it into my own practice.
Yeah.
Our residents, that's where they get most
Right.
of their education
I
at this
know.
point. Podcasts and online
Right.
places that have go-to experts that will render an opinion on almost any subject.
Right.
And suddenly our residents are
I know.
incorporating it into their practice.
I
And
know.
we can either universally say, well, no, that's wrong, or try to understand it.
Right.
And work.
Yeah, I'm a big sort of fan of like emergence, right? Of things that bubble up from below because they're right and they work. And whenever I come out against something like that, I feel like I'm being stodgy old man saying, God, don't look at that, but I don't know.
How do you put the concept of mental reversal within the idea of stratified medicine or personalized care, where, say, an example of the atenolol, maybe if the general population with hypertension does not work, but those that have a genetic predisposition to stroke, maybe those would be beneficial. And sometimes with this reversals, we sort of eliminate the medication for all.
Right. So I would never say that a reversal should lead to atenolol being, wiped off the planet, right? Because it may have effects. The problem is, and I know this is what you're saying, but this kind of drives me crazy, is that what usually people's response to it is, okay, well, you've proved it hasn't worked in this group, but you haven't proved it hasn't worked in this group, okay? And you can't go on just proving that things don't work over and over again. At some point, the person has to prove that it does work. And I think that's the battle of personalized medicine. And it's, I think, what the whole sort of next phase of research is going to be is that, okay, look, this really should work, and it should work in this group of patients because of what their, genetic makeup or their pharmacogenetics or whatever. But you got to show me it does, And then if atenolol comes back because 5% of hypertensives, their lives are saved by it, boy, that'd be great. Yeah.
One reaction I had is that if you get a new medicine approved, the manufacturer no longer has an interest in post-marketing surveillance. It's great, I'm selling lots of this product. A surgeon who says I've got a great new procedure for hip replacement doesn't have an advantage. Is maybe the answer that we need to do a better, maybe EMR-based post-marketing surveillance, so when a new indication or new procedure comes in, we then begin to have a locked-in prospective way to say, okay, is it still good at 2 years, 3 years? Is it still good when it's outside the study nurses and the very carefully selected surgeons for the RCT, but now it's been released to the general community?
That is such a self-interested question, isn't it? Yeah, I think so. I think hearing that sort of from the EMR perspective, when your denominator then becomes everybody who's treated, is wonderful. I think where we've run into trouble with post-marketing is all of these large case control studies of every side effect which could potentially happen, which sometimes maybe, okay, we learn that maybe using azithromycin in, really high-risk cardiac patients is not the smartest thing to do. But we also find out a lot of things that, the odds ratio is 1.8 and the outcome is, 1 in a million, and it's really unimportant. So I think actually your design is ideal if we can do that. Okay. Yeah.
In a society that prides itself on progress and innovation, and sort of rejects conservatism and prohibitory things, is it possible that medical reversal is a good rather than a bad thing? That is pushing the frontier, pushing the boundaries,
Right.
and always then having people
Push
check
back.
you up subsequently, and is that necessarily bad?
That's a great question. I mean, I think it's sort of thinking back to the old appendicitis mantra that, if you don't take out 5% normal appendix, you're doing a terrible job, right? And I think it's what the FDA battles with, because on the one hand, they have people saying, I want my new drug now, and then they have annoying EBM people saying like, oh, wait, we have to wait until a perfect RCT without surrogate markers with, endpoints 20 years in the future. I'd be much more comfortable with saying, look, this is the cost of a rapidly advancing field if we actually studied these things more frequently. I think the fact is that so often things get accepted and then the incentive goes away because I'm making a lot of money on this, whether it be the doctor, the pharmaceutical company, whoever, and we've got to recoup all those losses before I lose my patent. And so there's not a lot of time or a lot of incentive to do it. And the ethics generally then fall to, brave researchers or the NIH, because it's certainly not going to be funded by the people who are making money by it.
I'd like you to join me in a moment to thank Dean Coggeshall's 3 children, Dr. Richard Coggeshall, Carol Govan, and Diane Zink, for joining us today. And of course, we can't thank Adam Cifu enough for a wonderful, superb lecture. Adam, thank you.
Thank you. Appreciate it.